Please.
Respected chairpersons, dear friends, at the outset, my sincere thanks to Dr. Research and his team for this invitation. Definitely, the first visit to Europe, worth coming. So we'll be discussing about hyperprolactinemia. It falls in diagnosis and management, and as because it's a case-based approach, equal participation should be from your side too. So we can start now. This is a 30-year-old female having persistent galactoria and amenorrhea. This is a typical presentation which we have symptomatic hyperprolactinemia since last childbirth. Imagine after last childbirth for 12 years she is having this problem of amenorrhea and galactoria. She listed only for 1.5 years. And on the 1st July, the prolactin level was 120, and she was started on cabergoline 0.5 milligram bi-weekly. And on 14th of August, prolactin was 20, definitely with that cabergoline dose. And on 16th September, it was 2.2. CT SLR it was done outside. This was patient was referred to me. So outside CT SLR was normal. Pregnancy test at that time was negative. Estradiol, I have already mentioned, so any guess about the diagnosis? Amenorrhea, galactoria, 120 prolactin. We are behind schedule, so it has to be a bit quick. There is a hint about the estradiol. Okay, what will happen to estradiol when we have hyperprolactinemia? The amenorrhea occurs because of what? Do we have increased estradiol? Now any guess? Estradiol 440. It is definitely on the higher side, and I repeated the ultrasound. I had asked her to report on 14.8 itself. She came on 16.9, and that day her prolactin was that. And from that estradiol value which I had on 14th August, I had asked for the fetal well-being study, and this was 6 weeks pregnancy. So this is just to emphasize whenever you deal with the patient with hyperprolactinemia, always look at pregnancy test. She had this pregnancy test negative on 1st of July, but the answer is with the treatment of hyperprolactinemia, it was there. There was a betterment in her ovulatory cycle, and she later on became pregnant, and that is one reason why we do continue with the cabergoline treatment to go for fertility. So this implies that in patients who have amenorrhea, galactoria, and she had fertility with the institution of therapy. But this slide was just to project the need for pregnancy test whenever you come across a patient of hyperprolactinemia. This is the evaluation protocol, and this is a bit of a theory. So when you have, I have mentioned about the previous case had CT cellar, and the emphasis should be on MRI. Okay, definitely it's more informative when we are talking about the small lesions. When we talk of idiopathic hyperprolactinemia, these are cases who do have the hyperprolactinemia, which usually less than 3 millimeters, and that cannot be detected in the MRI. Patients may have macroprolactinemia, we will discuss about that angle, and patients may have anti-pituitary antibodies, and this constitutes idiopathic hyperprolactinemia. And the mention of anti-pituitary antibody is pertinent over here to just highlight the importance of autoimmunity even in producing the hyperprolactinemia. If you have a negative MRI, we need to think of rare conditions, not very common, is familial loss of function of receptor of prolactin. In these cases, there is no activity of prolactin, and hence there will be a rise reciprocal rise of prolactin level. So these are all the rare we need to take into account, and in a negative MRI, we should also think about the other neoplasms producing ectopic PLA. And this can arise from renal cell carcinoma. Recently there was a paper of ovarian carcinoma, and I have put in red about ovarian just to highlight the the significance of estrogen and prolactin, and even ectopic prolactin from ovarian tumor. This was regarding the immunity part. I told you the anti-prolactin antibodies. Just to highlight a recent paper again, the correlation of prolactin in celiac disease, and it is linear. You can gauge the treatment benefit with gluten-free diet with prolactin levels. And here they say that possibly prolactin may be the intermediary or it may be secondary in celiac disease. This is just to highlight the association of celiac disease in patients with lymphocytic hyperphagocytis. LIH is lymphocytic hyperphagocytis, just to give you a correlation of prolactin and celiac disease. On the right hand side, you find a mention of remission of LABA. This was again a very recent paper where they have shown there was remission of LABA after institution of cabergoline therapy, and we all know the hypoplasmic potency of cabergoline, almost 0.6% diminution of HbA1c at 3 months of cabergoline therapy. So this was to just highlight the immunological aspect. What was important for the previous case is the management part when you are dealing with pregnancy. So whenever your patient gets pregnant, we need to stop cabergoline, be it patients with microprolactinoma or macroprolactinoma. But in cases with macroprolactinoma, we have to be vigilant, which will be depicted in the other slide. And you see this is the older version. We treat macroprolactinoma at least for a year. We want to diminish the prolactinoma size to have less impact on the optic chasm. So this is the usual practice, and you can see DA is given for a year, and in that part, to avoid pregnancy, we go for mechanical contraception. Okay? But once the pregnancy is diagnosed, you stop the bromocriptine or cabergoline. Nowadays, they say straight away we can be there. It is safer to go for cabergoline because of its efficacy, because of its tolerance, and we don't now emphasize on the use of bromocriptine in pregnancy. So this is the algorithm. Pituitary Society 2023 is very recent. And with the previous slide, you go for the visual field estimations are every 3 months, and you need to go for an MRI if you have defective visual fields or there is severe ongoing headache. So this is the treatment algorithm, and definitely we go for surgery only in the second trimester of pregnancy, otherwise you can just institute cabergoline therapy. Now from the pregnancy part, this is the second one, 25-year-old with secondary amenorrhea, 2.5 centimeter adenoma with serum prolactin of 280. I think this is a simple one. Diagnosis. 2.5 centimeter adenoma with serum prolactin 280. So we have to give the full one, microprolactinoma, macroprolactinoma, giant prolactinoma. These are the things which we normally. This is not functioning because of stock effect 280?
Yes, you can.
No. It's usually less than 100. Okay, we'll come to another slide. So this is the case, and Manas was right to some extent. Otherwise, it seems patients of macroprolactinoma, 280, more than 1 centimeter size, but the class was this. And after peg precipitation, monomeric prolactin was only 27. So it was a case of phenomenon NFPA with macroprolactin. So again, to highlight the second case, the estimation of macroprolactin. Okay, and we will be discussing in one of the cases in our subsequent slide. And this is the estimation part, and this slide is going to you when to go for prolactin, stress medications, hypothyroidism, and then you have the NFPA and the tumors as such, and the importance of exploring macroprolactin. So pregnancy, macroprolactin should be borne in mind. This is a very nice slide. Just have a look about the stimulators and inhibitors of prolactin. Okay, on the top you have mention of stress mediated through serotonin and VIP. Then you have thyroid hormone and the glucocorticoids, the suppress prolactin, and if you have deficiency of that, there will be rise of prolactin. So you can get hyperprolactinemia in hypothyroidism, you can get hyperprolactinemia in Addison's disease. So very interesting things. Circling among we are well aware of. Now, this one. 56-year-old male having visual problems since 2009 was referred for management on 2nd April 2012. This was referred to me by another endocrinologist. March 2011 MRI brain, definitely a macroadenoma, prolactin level was 312. And with cabergoline therapy biweekly, she was there for a year of treatment now, and look at the prolactin nicely controlled, and TSH 7.9 was normal to 4.8. Okay, and the other hormones, estrogen, testosterone, cortisol, all were normal. This is a 50-year-old male. So the diagnosis, I think this is also a very simple one. Prolactin 312, 2.6 after a year of cabergoline therapy. This is it. Free T3, free T4. Look at the values. They are very rare. So this was a case of mixed adenoma. And this is a teaching. Whenever we go for the evaluation of gonadal function, thyroid function, we always go for free T4 and TSH. When we are talking about the central axis, the pituitary axis. So you should make it a practice to go for the free T3, free T4 and TSH at least. I most of the times I go for the 3, 4, FT3, FT4 and TSH. So this was a case of mixed adenoma, having prolactinoma, having TSH only. And anybody just from the, I don't think you are there. The gene which is linked with prolactin, TSH and growth hormone. Any answer? This should come from us. FET1 gene, linked with TSH, growth hormone and prolactin. Okay, now we are coming to the proper discussion. 30-year-old lady with serum prolactin of 52. And we are talking about pitfalls in diagnosis and management. And here we have these 4 treatments. A, no treatment. B is withdrawal or modification of previous treatment. C is surgery, radiotherapy, somatostatin, analog, steroids, and cabergoline. And D is the category of patients where we go for typical management of prolactinoma. Okay, so this is case A, 30-year-old lady with serum prolactin index scale 52 nanogram per ml. Patient is asymptomatic. Okay, and symptoms you all know: oligomenorrhea, infertility, galactoria, headache, visual problems. So these are the symptoms which we talk of in hyperprolactinemia. So in this case, asymptomatic patients repeat or normal. Okay, and these are the conditions which can lead to a transient increase, stress, chest wall lesions, and interestingly high protein diet and alcohol. It is preferable to go for fasting prolactin. Okay, and the things which I could correlate previously is to ask for PCT, post-coital test. Okay, and that is to be given between 2 to 4 hours, and that incorporated the 3 things: exercise, breast stimulation, and coitus. And coitus is not directly linked with hyperprolactinemia; it is linked to stress to some extent. And if the repeat test, this is the normal in transient cases, if it is increased, we need to go for macroprolactin. Okay, so this is the algorithm for this, and this is the mechanistic part: high protein, L-arginine, L-tryptophan linked with increased serotonin, and that linked with increased prolactin. Alcohol, suppression of dopamine. So these are the 2 things which are definitely not a routine to think of, and they can lead to increased prolactin. And the clinical evaluation, if the symptoms are not there, we need to go for macroprolactinemia, which is negative. We need to repeat the prolactin test with half an hour rest, just to avoid the stress. Now we are coming to the macroprolactinemia, hyperprolactinemia, the significance of it. This was a series where it was in patients with PCOS, and all 6% patients had macroprolactinemia who had a hyperprolactinemia. This is just to emphasize that even in PCOS patients we can have a hyperprolactinemia, and if you estimate macroprolactin, we can have almost all the patients having that. So that underlies the significance of macroprolactin estimation. This is it. Macroprolactinemia, more than 50% of the circulating is macroprolactin, and this is the prevalence, 10 to 46%, and look at the value. 20 to 663, and remember our first case, it was 280 and it came down to 27 of monomeric insulin. So just imagine the percentage of macroprolactin which was there. And there is variability in prolactin assays to the tune of 2274. And also we should not forget to always remember iodine in thyroid estimation. But this is there in prolactin assay too. And it has to be stopped at 2 to 3 days before going for prolactin estimation. And the recommendation is, should we go for macroprolactin in all hyperprolactinemic individuals? I think we should. All the other things, if you have conflicting prolactin results in different assays, you need to be wary of this condition. Okay? And if there is delayed decline of serum prolactin with usual levels of dopamine, you should think of this. So, the first index case, prolactin 52, first case repeat was normal, and the second type was asymptomatic patients, macroprolactinemia was there, so it doesn't require treatment. This was the first category. Now case B, this is linked with the drugs of the different conditions. Majority of the cases here, prolactin is less than 50, it may rarely exceed 100. I have seen patients with levocirpiride even going to 200. Okay? And the drugs, as you can see, the dopamine receptor antagonists, even estrogen preparations can produce that, hyperprolactinemia is there, and we all know about the association with hypothyroidism, chronic renal failure, severe liver disease, and in PCOS is fortuitous, just by chance association, and 6% patients were there with macroprolactinemia. The explanation is linked with prolactin clearance and dopaminergic tone, be it the hypothyroidism, be it renal failure, and for the dopamine antagonist, it is preferable to stop the drug 4 to 7 days before prolactin estimation. You always get this. Referred by gynecologists with raised prolactin, and we have to practice this, stopping the drug for 4 days, preferably 7 days, and going for repeat prolactin. So this is another message for evaluation of macroprolactinemia. This we have talked about the thyroid and the estrogen in that. And how to approach the patients with hyperprolactinemia and psychotic agents. We need to prefer drugs which have less interaction with prolactin, and this includes erbitrazole, olanzapine, and depresidone. Okay, and if ongoing therapy is there, we need to look for prolactinoma with MRI, and if there is concomitant hypogonadism, we need to go for estrogen replacement therapy. Okay, monitoring of prolactin, as I told you, it can lead to elevation of up to 40 nanograms per ml, but this is not a choice if the patient is opting for fertility or if the patient is having allopuria, so that will aggravate the condition. Okay, otherwise for hypogonadism, you can go for estrogen replacement therapy in patients who are on antipsychotic treatment, because we all know cannabinoid clonidine can aggravate the psychiatric problem to some extent. Now, continuing with PCOS and hyperprolactinemia, this was a patient of hyperprolactinemia having typical features of PCOS, and she was well controlled on cabergoline. This was just to highlight the association of hyperprolactinemia, and again for clinical practice, the optimum cutoff. So if the value is more than 53, we need to go for the MRIs. This underlines again, if you are having drugs or the patient is having hypogonadism, you have to withdraw the treatment, go for the antipsychotics which are neutral to prolactin, and modification of treatment in the form of hypogonadism treatment. Case C is again, as was highlighted by Manas, pituitary stalk interruption. Okay, and the other entity is Cushing syndrome and Nelson syndrome, and they are linked with prolactin gene transcription. Additions I told you in the previous slide. This is in patients with acromegaly, the role of cabergoline 1 to 4 milligram, and definitely better response in patients who are having high prolactin. Similarly for Cushing's disease, role of cabergoline in treatment, but it is not that consistent, and there is wearing of the effect of cabergoline. So in this case, in this category, stop interruption, the We need to treat the other causes, the other adenomas, the surgery by radiotherapy, somatostatin analogs for the management of acromegaly, steroid for lymphocytic hepatitis, and tuberculin again for the adrenal and both hormone tumors. And the last part, we are coming to typical treatment of prolactinoma. This was an index case, and if this cutoff of 204 has been taken for micro and macroprolactinoma. With lower values, we need to go for the hook effect. You go for the repeat MRI only if you have increased prolactin on dopamine agonist or marked increase of the pretreatment levels after dopamine has been discontinued. So repeat MRI again, we need to bear in mind. It is done when there is increased prolactin on dopamine agonist therapy, or once you have stopped and you repeat test, there is a further rise when the initial evaluation which you had. This is again the treatment protocol. As you can see in menopause, you can go for observation. Premenopausal state, in hypogonadal state, you can go for HRT. Important again when to stop it. For microadenoma, it is 2 years. For macroadenoma, 5 years. And on macroadenomas, you have to taper it. Microadenomas, you can straight away stop after 2 years. An ideal person is when you have monoprolactinemia for at least 1 year with minimum dose of 0.5 milligram, and you don't have a visible tumor MRI, or there is reduction of 50% in the mass. You can also go for 2-weekly therapy. I have patients of mine where I have kept the patient on chloroquine every 2 weeks. And this is a bit different from the literature, but the evidence is over here. And because of the continued half-life, the longer half-life in hyperprolactinemia state, we can go for chloroquine treatment every 2 weeks. But clinically, and the recommendation says it should be weekly. You can reduce the dose, but keep it weekly. This is the word of true dopamine resistance, and the agents which we can use are pituitary and temozolomide, particularly reserved for patients with pituitary carcinoma. But if a patient is not responding, we can go for temozolomide therapy. And then I think this is the second last slide. Impulse control disorders can happen with either bromocriptine or tuberculin. This is more common in males, but this can happen in females also. And look at the clinical parameters: hypersexuality, binge eating, gambling, and compulsive shopping. These are all part of impulse control disorders seen in 25% patients being treated with either bromocriptine or tuberculin, and you can reduce this by reducing the dose. Better if you can stop tuberculin. So this segment is treatment of prolactinoma as such, preferably with tuberculin. Side effect profile is less, efficacy is better, and in patients who are having hypogonadism, in occasional patients, you can go for estrogen therapy, particularly premenopausal having hypogonadism symptoms, and in resistant cases, we need to go for temozolomide. So the 4 segments I have talked about, the pitfalls and the management differences in the patient with a similar prolactin level. And thank you all for the patient hearing.